Good evening, sir.
गुड इवनिंग मैडम, गुड इवनिंग।
सर मेरा एक्चुअली कैमरा एक्सेस क्यों नहीं हो रहा पता नहीं।
मेरा आप बंद करके फिर से ज्वाइन करो, कोई ऑप्शन नहीं इधर से, तो आई कांट हेल्प यू।
सेटिंग्स में चेक कर दो सर एक बार। अलाउ शो कर दो।
सेटिंग में कुछ नहीं रहता ऐसा। यू लीव द मीटिंग एंड अगेन ज्वाइन इट।
ओके ओके सर, थैंक यू। सर अगेन सेम प्रॉब्लम।
नो मैडम, आई कांट हेल्प एनीथिंग।
आई नो सर, मैं मैं ट्राई कर रही हूँ, ऐसा होता नहीं कभी। आई डोंट नो ये क्यों हो रहा है। आई जस्ट चेक वन। सर sir, our speaker Shambhika sir is asking for permission for recording rights to drink. So can we, sir?
हाउ
Dada
ही
sir?
विल
Yes.
already recorded and started. Yes, give the permission for recording. Actually live streaming is started. It will record also, and this will be a live streaming.
Sir, I'll join from laptop, sir, क्योंकि इसमें कैमरा एक्सेस नहीं हो रहा मुझे। I don't know what is the problem. मैं ट्राई
हाँ,
कर
तो
रही हूँ बट still it is not
you
working.
may have your laptop you may have not given permission of camera, so it is not happening.
सर
You
लैपटॉप
join
से ही मैंने अभी तो मोबाइल से ज्वाइन किया सर।
मोबाइल, वो लैपटॉप से कैमरा है क्या लैपटॉप को?
यस सर, यस सर।
तो आपको सेटिंग में जाके कैमरा को परमिशन देना पड़ेगा।
जी सर, जी।
And second thing, already recording started in on YouTube. If sir wants to record at their end, they can record.
Dr. Chaitanya, sir, you are muted. Kindly unmute yourself and then. Hello, Dr.
Sir,
Chaitanya,
please
sir.
unmute yourself. Sir, we cannot hear you. You'll need to unmute yourself, sir. Sir, the option is on lower left corner. Dr. Archana, please unmute, sir.
Yes ma'am, yes ma'am. Ma'am, actually I'm not the host. ये दो बार I'll leave and join again ma'am. Just a minute.
Archana, you are the host. Archana, ma'am, you are the host.
Arpita ma'am, you are the host now, I guess.
Yes. Yes. I've given you the rights again, Archana. Now you're the host. We can start with the
Yes, ma'am.
session, I think.
Yes,
Yes.
Arpita ma'am, am I audible?
Yes, is you audible. I request everyone to please mute yourself so that we can listen to the speaker.
Hello, Archana ma'am. Kindly
Yes,
make
yes.
me co-host.
Yes, yes, definitely. Just a minute. I will.
Dr. Ganesh, please mute yourself. Dr. Ganesh Jagtap, please mute yourself.
Priyanka ma'am has joined, na?
Yes, yes.
Ma'am, we'll wait for 5 minutes to join more participants, then we'll start. Sir has joined with us. Shindika sir has joined.
If you can make me host, I think I'll be able to share the presentation. Otherwise, at
Sure,
where I'm
I'll do.
share the presentation.
Yes, sir, yes. Sir, I've made you host. Good evening, sir.
Good evening, Archana. How do I do this? I don't know because
So share screen.
share screen नहीं दिख रहा मुझे.
सर आपको होस्ट बनाना है तो आपको option आना चाहिए.
Whiteboards. Yes. Yes. Okay. यस इसमें है वो मोर में है शेयर स्क्रीन ठीक है. हाँ अभी कर सकता हूँ मैं जब भी अपन चालू करेंगे तो आई शेयर.
Priyanka ma'am, can we start? Kindly mute yourself, please. Participants, requesting everyone to kindly mute yourself. Sir, kindly make me co-host, sir. Jagruti, can you make me co-host?
No, ma'am, I can't. Only host can make.
So Shembika, sir. Sir,
Yes, Archana, I am co-host.
Jagruti, am I audible? Sir, I know, sir. So please make me co-host.
Uh,
So click on my name, you will get the options.
So just go to participant list.
yes,
Yes, participant list में click on my name, so you'll get the options.
yes. You were already your co-host. Now you are co-host.
Yes, and now I'm the co-host. Thank you so much, sir. Priyanka ma'am, can we start? Priyanka ma'am? Priyanka ma'am is
Doctor, I
not
think
joined.
ma'am is in transit. I think we can start. It's already seven
Okay,
seven.
okay. Yes, yes, yes. Good evening, everyone. Myself, Dr. Archana Pandey Jumle, coordinating today's webinar with my co-coordinator, Dr. Jagruti Patel. I am extremely glad to welcome you all to this much-awaited webinar. This is 42nd webinar of our webinar series organized by Nima Obgy Society Central Body. Before starting a session, I request all the dignitaries and the participants to take blessings of Lord Dhanvantri. For this, I would like to invite Dr. Jagruti Patel for Dhanvantri Savan. Dr. Jagruti?
Yes, ma'am. Thank
एक
you.
दोन हाफ
Just
कॉफी.
Requesting everyone to please mute yourself.
yes.
Yes,
शङ्खं
Jagruti.
चक्रं जलौकां ददतमृतघटं चारुदुर्दिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्यां शुकपरिविलसन् मौलिमम्भोजनेत्रं कालाम्बोदोज्ज्वलाङ्गं कटितटविलसच्चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवनं प्रौढदावाग्निनीलम् प्रौढदावाग्निनेत्रम्. Thank you so much, ma'am. Over to Dr.
Thank
Archana.
you, Dr. Jagruti. May Lord Dhanvantri bless us all with good health. Continuing further with the webinar, I welcome all the dignitaries and delegates for today's knowledge enhancing session on the topic Save the Uterus. To start, let us welcome all the dignitaries of our Nima Obgy Society Central, President Dr. Kamini Dhiman ma'am, Secretary Dr. Priyanka Nakade ma'am, Treasurer Dr. Vishnu Bhavne sir, and National Convener Dr. Rajesh Uthane sir. I would also like to welcome dignitaries of Nima Obgy Society Maharashtra Chapter, President Dr. Suhas Elika sir, Secretary Dr. Manoj Gaikwad sir, Treasurer Dr. Ajay Rajbal sir. I welcome you all. Now continue with our 42nd webinar of the series on topic Save the Uterus. We are honored to have here amongst us very eminent speaker and my guru, respected Dr. Chaitanya Shembika sir. It's my honor and privilege to introduce all of you to respected Chaitanya Shembika sir. Sir is MBBS gold medalist, MD, FICOG and FICMCH. Did his diploma in pelviscopy from Germany. Sir is chairman and MD, Omega Hospitals Private Limited, Nagpur. Sir is past president of Nagpur Obgy Society. Sir is chairman of Infertility Committee, AMOGS, and Emergency Obstetrics Committee. Sir has n number of achievements and awards to his credit. To mention few, Sir has received Kamini Rao Yuva Foxy Oration Award, Dr. Kumud Tamaskar Oration and Presidential Oration Award, NOGS. Sir has received MS Signature Award at the hands of Honorable Union Minister Sri Nitin Gadkari. Sir is recipient of AMOGS V43 Award at the hands of Maharashtra Governor Honorable Sri Bhagat Singh Koshari at Raj Bhavan. Sir is member of Infertility Committee, Clinical Research Committee, Endocrinology Committee, FOXY. So with due respect, I would like to request our today's guest speaker, Dr. Chaitanya Shembika sir, to deliver his talk on Save the Uterus. Before starting the session, my sincere request to all the participants to kindly keep yourself muted because it is very disturbing for the participants and for all of us. Thank you so much. I request sir to start his talk.
Thank you so much, Archana. It's a pleasure to be with you. I would now try to share my screen because initially I was able to share it. Now it seems it is not possible. I don't know why. But
Sir,
uh,
say more options.
uh,
Sir, actually, I can see direct share option. I'll just check you are host or not, sir.
yes, now
Just
it is
hold
a
on.
now there is a direct share option, right?
Yes,
Because
sir.
initially it was not there. Now it is there,
Yes, sir.
right?
Yes, sir. Because
So
that you were only co-host, that's why.
now I hope you all are able to see
Yes,
my presentation. Right. I'm going to discuss today a very interesting and important topic that is abnormal uterine bleeding. Save the uterus. Um, and I bring greetings from Omega Hospitals Nagpur, along with Nagpur OBGYN Society, where I have worked as a president. My special thanks to Nima for giving me this wonderful opportunity, and of course, I must thank and mention here that Archana is I know her since last I guess 15 years, and I've seen her working and growing. She is a sincere and dedicated, hardworking clinician, and I'm very fortunate to have you, Archana, as my. As you have worked with me, I am really fortunate to have you with me. Then we have Dr. Kamini, Dr. Priyanka, Dr. Vishnu, Dr. Rajesh, and Dr. Jagruti. I must thank everybody for giving me this opportunity. Now I would start with the topic which I'm supposed to discuss today, that is save the uterus, and why we I have selected this topic or why I have chosen this topic, because there is a reason behind it. There was an LAQ, ज्याला आपण मराठीमध्ये लक्षवेधी सूचना म्हणतो, in a Maharashtra Legislative Assembly on hysterectomies done in Beed district of
दूध बिस्किट
Maharashtra.
पाहिजे चहा
अ,
बिस्किट
बीड जिल्ह्यामध्ये अ, ऊस तोडणीसाठी जाणाऱ्या महिलांना मोठ्या प्रमाणावर हिस्टेक्टॉमी करण्यात येत असे. आणि द प्रॉब्लेम वॉज की ज्या बायकांना मुलं झाले त्यांनी कामावर व्यवस्थित हजर राहावं म्हणून they used to remove the uterus of all the women working in the fields so that they don't take leave for the menstrual reasons, and this is really horrible. And there was a LAQ, then the inquiry was committee was there, and then this inquiry committee, they decided to have SOPs and standard operating procedure for doing hysterectomy in any patient with abnormal bleeding. And now the government has come up with the notification that you are supposed to notify government and also justify if you are doing hysterectomy in a woman who is less than 40 years of age. So this is a very important point, my dear friends, and this is an eye opener for all of us, that we should keep this in mind, that whenever a patient comes to you, if she is less than 40 years of age and if you are planning hysterectomy in that patient, you have to notify to the government and explain to the government that why at such a young age you are doing hysterectomy. So hysterectomy should be done very, very carefully and only when it is really required. Now we will start with the basics of abnormal uterine bleeding. When we were in college, during our college days, there were definitions which we used to mug up, like menorrhagia, metrorrhagia, oligomenorrhea, hypomenorrhea, polymenorrhea, DUB, epimenorrhea, etc. Menorrhagia means prolonged bleeding. Metrorrhagia means intermenstrual bleeding. Breakthrough bleeding, where the bleeding is there in between the menses. Oligomenorrhea is scanty menses. Hypomenorrhea is where the flow is diminished and the cycles are short. And polymenorrhea is frequent menses. But now, the FIGO has said that this nomenclature is no more used in the definition and the diagnosis of abnormal uterine bleeding. And this is these are the terminologies which are now abandoned, rejected, and discarded. So what they say is nowadays it is labeled as heavy menstrual bleeding. I remember during our college days, the nomenclature was FUH, that is functional uterine hemorrhage. Then that nomenclature changed to DUB, that is dysfunctional uterine hemorrhage. So functional become dysfunctional uterine bleeding. Then it was changed to AUB, means abnormal uterine bleeding, and now it is called as heavy menstrual bleeding. See how the nomenclature is changing and the guidelines are changing. And now, for any heavy menstrual bleeding, the patient coming to you with heavy menstrual bleeding, there is a palm coin classification which is to be kept in mind. So, what is this palm coin classification? We have palm means P for polyp, A for adenomyosis, L for leiomyoma, and M for malignancy. So these are the structural defects which can lead to bleeding. And then we have coin, where C is for coagulopathy, O means ovulatory dysfunction, E means endometrial cause, I is iatrogenic cause, and N is non-defined or cause or where the cause is not known. That means all the coin classification goes into non-structural causes and the palm classification goes into the structural causes. So it is very simple and clear to all of you. So this is what is palm coin classification. Now, what is the impact of heavy menstrual bleeding on the quality of life? It is the quality of life which is important for every woman. She should be able to work properly. She should be able to work efficiently. There should not be any anxiety. There should be no depression. There should be no decrease in the work productivity. There should be no anemia. Patient should not have discomfort. Patient should not have pain. And there should be no negative impact on the sexual relationship. So overall, the quality of life is decreased whenever the patient has got abnormal uterine bleeding. Now it has been found that in 60% of women where there is a problem of bleeding, they end up in hysterectomies. And if you just look at the statistics say that one third of the hysterectomies are not necessary. That means you can avoid so many number of hysterectomies, which is possible if you actually do the things properly. The incidence is very high, and almost 30%, and 50% of these patients are of perimenopausal age group. So around 45 years is the age group where you get maximum problems of abnormal uterine bleeding. And many patients with postmenopausal bleeding also will come to you. Now, this postmenopausal bleeding needs a special mention because whenever I think Achana, somebody is speaking in the background, so maybe you can ask everybody to mute themselves so that the others will be able to listen to my talk properly. So I think
My
somebody is,
sincere request to everyone,
yeah,
kindly mute yourself. It is very disturbing for the speaker. Kindly mute
yeah,
yourself.
yeah, it's okay. So postmenopausal bleeding needs a special mention because whenever the bleeding is after menopause, whenever the bleeding is after menopause, the cause is many times benign. So you should not get panic कि पेशेंट 60 साल की है या 55 years की है और उसको ब्लीडिंग हो रहा है इसका मतलब मैलिग्नेंसी है, ऐसा सोचने की जरूरत नहीं है. Because many times it is atrophy of the vagina or a small polyp which can be a cause of bleeding. But at the same time, you should remember that your role as a physician becomes more important because the chances of malignancy in this age group are high. So your job is to rule out malignancy so that the patient knows that there is no cancer as a cause of bleeding. And this is what is important in this age group. So what is important? You should actually do proper investigations after doing examination. TVS is nowadays gold standard for the diagnosis. TVS is always done first after doing proper examination and taking proper history. Along with TVS examination, you may go for MRI because MRI is becoming more and more important nowadays because MRI is one investigation which can actually give you a clear idea, especially in pelvic problems. So in pelvic problems, MRI is an important investigation. Hysteroscopy. Hysteroscopy to see the cavity from inside and to treat the problem immediately in the same setting is also becoming important. And finally, you can take a biopsy so that you are confirmed or you are sure that there is no malignancy or the malignancy is ruled out. Now, what is important is you should offer something different. If you offer something different to your patient, the patient will come to you. You don't have to go to the patient. So what is important is you should give them options of saving the uterus, because uterus निकालने वाले तो बहुत है, uterus निकालना बहुत आसान है, लेकिन uterus को बचा के रखना ये एक challenge है, और ये challenge हम सब ने accept करना चाहिए, and we have to see to it that how we can save the uterus. Now I'll give you a very brief description of various cases. This is case number 1. This is a 59-year-old lady. You can see the hysteroscopy. You can see the movie. This patient is a 59-year-old lady. She came with postmenopausal bleeding. We did her ultrasound. There was a thick endometrium. So whenever thick endometrium is there, the first thing that comes to your mind is probably this is malignancy. Then we decided to do her hysteroscopy. And when the hysteroscopy was done, it was see and treat policy. We found that there was a polyp, a small polyp. And when this polyp was removed, the patient stopped bleeding. This was a benign polyp and her problem was solved. That means a simple procedure of hysteroscopy can save the uterus. Similarly, I'll show you this case. This is an interesting case. A 56-year-old lady, she is a known case of hypertension, obesity, and she is on aspirin as advised by physician. As you know, most of the patients nowadays are taking aspirin for various reasons. And you can see this hysteroscopy. There was a polyp, and also the endometrium was highly vascular. And you can see the vessels on the endometrium. You can see the red endometrium. It is angry red endometrium. So the vessels were seen on the endometrium, and endometrium was thin. Now we talked to the physician and we asked them if we can stop the aspirin. The physician said there is no problem. We are giving her aspirin prophylactically. You can stop the aspirin. We stopped the aspirin and the patient stopped bleeding and the hysterectomy was saved or hysterectomy was avoided. So this is another example. Now a third case. She is a young lady. This lady came to me with the diagnosis of query vesicular mole. See, I have given you the ultrasound report which says query vesicular mole because there was a thick endometrium. We did her beta ECG, it was negative. She was 39-year-old lady with 2 kids and she was on the drug Sevista since last 2 years. Sevista is a centromine, which is a drug given for the treatment of AUB. She was on this drug for 2 years. I will tell you the importance of Sevista as we discuss further about this AUB. And when we did a hysteroscopy, we found that there was a thick endometrium and there was absolutely no other problem. Then we came to the conclusion that it is a Sevista or centromin which is causing her thick endometrium. We did her curettage, DNC was done, her report was normal. After 1 month, we subjected her to balloon therapy or thermal ablation. I will tell you about thermal ablation later on, and the patient's hysterectomy was avoided. So, 3 simple examples where you can see how the hysterectomy can be avoided in the patient of abnormal uterine bleeding. Now, as I told you, hysteroscopy is the gold standard. If you know how to do hysteroscopy, you will be able to diagnose so many things. It's like a see and treat policy. You can see the polyps. I have shown you 3 examples where hysteroscopy was done in all the 3 cases, and the patient got benefited because of the hysteroscopy. And this is the treatment which is very commonly done nowadays. We use hysteroscopy regularly, and at our Omega hospital, we are using 2.9 millimeter Betochi hysteroscope, which is a small, very small hysteroscope, which gives you very good vision, and you are able to diagnose the condition and treat the condition in the same sitting. So it's like a see and treat policy. So a positive mind finds opportunity for everything, and a negative mind finds fault in everything. So if you want to find opportunity in everything, you should have a positive mind, and that is what is the saying. We come to the medical management of abnormal uterine bleeding, and there is a long list of drugs which are available for medical management. These drugs include ulipristal, which is used in fibroids, mifepristone, which is also used in fibroids, dynogest, which is used in endometriosis, centromine, which is also known as Saheli. You know Saheli, you must have heard the name Saheli. Saheli is a drug which is used for contraception, but the same drug can be used for the treatment of AUB. Then we have leuprolide acetate injection, which is also called as leupride depot injection. And then we have Mirena, which is actually a LNG IUD or intrauterine device, which is used for the treatment of menorrhagia. So we have this cafeteria approach. We have so many drugs which are available. We'll discuss one by one all the drugs. I'll tell you about ulipristal first. Ulipristal is a drug which is used for the treatment of fibroid. I was lucky to that I was a principal investigator for the clinical trial of this drug which was called as Pearl trial. This Pearl trial was very famous, and this was a trial which was done in 4 to 5 centers in India, very few centers in India, and our center was one of the centers. And we did many patients. It was a Pearl 1 trial, and this drug we tried to find out how it is working. So it works on the fibroids, reduces the size of fibroid. It works on the HPO axis and inhibits the ovulation, and works on the endometrium and makes the endometrium thin. This drug is available as 5 milligram and 10 milligram tablets. Ultimately, we found that 5 milligram is a good drug, and it was a very strict trial. We tried to include 30 patients. Out of 30, only 7 patients were recruited. And out of 7 patients, we found that 3 could be managed without surgery, and 2 patients had no response, and 2 had good surgical outcome with the reduction in the size of fibroids. So we found that overall this drug is good for the reduction of the fibroids and reducing the bleeding. Now there is a something called as the safety precautions or serious adverse effects. And SAEs are important because if you have SAEs, then it is a very dangerous situation. Luckily, at our center, there was no serious adverse effect, but this drug is known to cause hepatotoxicity. Friends, it is important that you should know this, that this drug is known to cause hepatotoxicity. And finally, there was a big controversy on this drug. And the controversy was so big that this drug was withdrawn from the market because of the hepatotoxicity, because there was a death reported with this drug. So now this drug is again available, but with a rider. Now people say that you can use this drug, but very carefully by doing liver function test every month. So most of the patients have stopped using this drug. Now the second drug, mifepristone. You must have heard the name of mifepristone. Mifepristone is the drug which is used for abortion. The same drug is an alternative to ulipristal. It is a cheap drug because it is one third of the cost of the ulipristal. It is available as 10 milligram and 25 milligram tablets, and we have started using this drug quite often in the patients with abnormal uterine bleeding and fibroids. There are many studies which say that it reduces the blood flow and reduces the size of the fibroid. And the biggest advantage was safety. It was much safer to use mifepristone as compared to ulipristal. But the only thing is, it is not totally free of side effects. 100% safety is not there. Still, there is a possibility of hepatotoxicity, and therefore you should do the liver function test. Then comes the third drug. So I have discussed about the ulipristal. It is not used nowadays, not a very good drug, but then mifepristone, which is okay. Third is Dynogest. Dynogest is the most popular drug nowadays. Why? Because it is cheap. It has got minimum side effects or no side effects. And the third and the beauty of this drug is that it can be used for a long term of almost 5 years. Now, what are the conditions where the Dynogest is used? Endometriosis, where the patient has got adenomyosis, where the patient has got bleeding with pain. All these conditions, Dynogest works very well. And therefore, it is a drug of choice in the treatment of endometriosis and adenomyosis. And it is available as 2 milligram tablet to be taken once a day without break. And there are now clinical trials which say that you can give it up to 52 weeks. That means you can give it, and there are drug trials which are now coming that you can give it for almost 5 years. So the new drug trials say that you can give it for 5 years. So definitely you can give it for 1 year. That is for sure without any side effects, and that is the beauty of this drug. So this is a drug which is now becoming very popular. Then I have told you about Centroman. Centroman is also called as Saheli. This Saheli is, you must have heard of this drug. This is a contraceptive drug. It is to be taken once or twice a week. Now, this is the drug which is used by many gynecologists for the treatment of abnormal bleeding. But a word of caution, I never use this drug. Why? Because I have an experience, which is a bad experience with this drug, that the endometrium becomes thick. The lining is thick, and I have shown you the third case. You remember the third case? I have shown you the third case where I have shown you how the endometrium becomes thick, and the radiologist gave the wrong diagnosis of vesicular mole because that radiologist thought that probably this is a vesicular mole. So endometrium becomes so thick. This is the side effect of Centroman, and therefore Centroman is not a very good drug. It can be given once or twice a week. There is one more injection which is available in the market, that is called as Leuprolide or Leupride depot injection. Leuprolide is the drug which is called as GnRH agonist. It suppresses the HPO axis, and by suppressing the HPO axis, it actually is responsible for reducing the size of fibroids, reducing the pain associated with endometriosis, and reducing the bleeding associated with AUB. So this is the drug which is used very commonly in abnormal uterine bleeding, fibroids, adenomyosis, and endometriosis. Now, the advantage of this drug, it is depot preparation. You can give it for once a month, that is 3.75 milligram, and 3 months depot preparation, 11.25 milligram. It is an intramuscular injection, but you cannot give it for long term. You can give it for 4 months or at the most 5 to 6 months. Second thing, this is the drug which is known to cause osteoporosis. This is a drug which is known to cause the side effects like menopause. So patient will have hot flushes, patient will have night sweats, and patient will have menopausal symptoms with this drug. And the most important thing is osteoporosis, and therefore this drug is also good for short term use but not good for long term use. So this is the drug which is good for long short term and not for long term use. Next is the Marina. You must have heard of Marina. What is Marina? Marina is intrauterine device which is used for the treatment of menorrhagia associated with all these problems. It contains levonorgestrel, which is released very slowly over the period of 5 years in the dose of 20 microgram every 24 hours. So per day, 20 microgram of this LNG is released. And the advantage of this drug is it is for 5 years. So you put it and forget it. That is the biggest advantage. So you have to put it, but it is like a copper tea. So some patients they are not very comfortable. Not they are very anxious. They say that मला copper tea suit होत नाही, मला copper tea चालत नाही, sir मला हे टाकू नका. पण I try to convince patients because this is the drug. रोज गोळ्या खाण्यापेक्षा कधी पण you put it in the uterus and it will work for 5 years. That is the advantage. So we try to convince the patient because you can actually avoid the hysterectomy with this Mirena. It is good for fibroids, it is good for adenomyosis, it is good for endometriosis, it is good for AUB, and it also gives you additional protection of contraception. So it is a contraceptive also, and that is the advantage. It makes the endometrium thin. See how the endometrial lining becomes thin when you put it, and the patient's menstruation is reduced. So either patient gets scanty menses or no menses at all. There is a procedure which is important, and you should know how to put this Mirena inside. I must tell you that sometimes you may require anesthesia because it is not very easy, but mostly it is done without anesthesia. As you can see here, this is the video how to put the Mirena inside. So you have to see the uterus cervical length, and then you have to advance the Mirena and put it inside. Open the flanks. So like this, you pull it and open the flanks, and after you open the flanks you push it down again towards the fundus, and then pull the plunger so that the Mirena stays inside the uterus. Very rarely we may actually do it under anesthesia, but because if the patient is not able to tolerate the pain, you may have to give anesthesia, but usually it is done without anesthesia. As you can see, the bleeding becomes less with the Mirena and the pain also becomes less. But you cannot, there are some contraindications for this Mirena. You cannot give it if there is an infection. You cannot put it if there are patient is on anticoagulants. If the patient has got migraine because it leads to fluid retention and the patient may have migraine attack may increase, or patient may have more headache and liver diseases, of course, you cannot give because it's the progesterone. Then there are some side effects which are also important. Patient may have pain. It may be difficult to insert it. As I told you, you may require anesthesia. The patient may have problem for 3 months, and this is an important point. This is a practical point. And if the patient comes to you with Mirena inside, she may be not be very happy for first 3 months. So you should remember, you should tell the patient that you should have some patience. Wait for some time. This Mirena will take some time for its action to start, and therefore, first 3 months, you may have some bleeding, some pain, discomfort, but tolerate it. And after 3 months, the patients are very happy, and then they say, "Thank you, doctor. तुम्ही आम्हाला थांबायला सांगितलं. We are happy. आपने हमको बोला कि आप रुक जाओ, लेकिन अब मेरे को अच्छा लग रहा है, and I am now happy." It may lead to perforation, spontaneous expulsion, and pigmentation. Spontaneous expulsion is also one more thing which you should know, because this sometimes the bleeding is so heavy that Mirena may wash out, may come out along with the bleeding. This is something which you should know, and this may lead to pigmentation for a long period if you put the Mirena inside, because it's a levonorgestrone, which is a progesterone. You may get pigmentation on the skin, and this pigmentation is sometimes very, not very, patients are not very happy with this pigmentation. So you should keep this in mind, that patient may get pigmentation because of Mirena. Now in our hospital, Omega Hospital, we have statistics. We we use it quite often. So last 6 months we have inserted 11 Mirena. Out of these 11, we required anesthesia in 2 cases. One patient, it came out expulsion. After 3 months, there was a problem in almost 5 patients. And one thing which I would like to tell you is you can use various now. So we have discussed all these drugs till now. Mirena was the last drug which we have discussed. You can use some drugs in combination. How you can use it in combination, I'll tell you. As I told you, first 3 months, Mirena may take some time for its action to start. So what you can do is you can give Lupron injection. Lupron injection can be given for 3 months, and then you put the Mirena at the same time you give Lupron injection. Lupron injection will work for 3 months. Then you stop Lupron injection, Mirena will start functioning. This is how you can use your clinical acumen. You can use your clinical knowledge and provide relief and help to the patients. The patients are happy because of your expertise. Nowhere it is written that you can use combination of Mirena and Lupred, but you can try this. And I have tried this in couple of my patients. In 3 of my patients, as I discussed here, patient got dramatic relief of pain and bleeding when the combination was used. Why? Because sometimes the fibroids and adenomyosis, they give severe pain, and this pain is so difficult to tolerate and handle that the patients, they come, they are yelling, they are in agony, they are crying. And then in that situation, you if you just help them by giving them a combination of Lupred along with the Mirena, the patient are definitely getting relief and they're happy. So I'll give you the markings now for all the drugs which we have till now discussed. This is my marking system because I have this experience of almost now 27 to 30 years where ulipristal is I have got side effects and therefore it's a problem of hepatotoxicity. It is costly also, and it is I will give you 6 out of 10. Mifepristone is good, but I'll give 7 out of 10 because it is less toxic as compared to ulipristal. Danoist, I'm very happy with Danoist, but if it works very well. So here I'll give you 8 out of 10 marks. Centromine, I am not happy with centromine, so centromine I'll give 4 marks. Then Leupride, I am happy for short term, so 6 out of 10 marks. But Leupride, the problem is of menopausal side effects, as I have told you. It is good for fibroids and endometriosis. And last is levonorgestrel, which is good for fibroids, endometriosis, and AUB. The problem is only of expulsion and difficulty in putting the drug Mirena, and also the first 3 months of Mirena are sometimes problem. But it was initially almost 8,000 to 10,000 was the cost, but now the cost is reduced to I think 3,000 something. So it is quite cheap now, and it is long term. So I will give almost 8 marks to Mirena. So Mirena and Danolis are the two drugs which I am using in my day-to-day practice, and they are doing very good job. A man who masters patience masters everything, and this is what is important. This is very true in the medical management of UAB. You should have patience. If you have patience, then definitely these drugs are going to help you. Now some other treatment options which are available: uterine artery embolization. UAE is done by radiologists, where the embolization of the uterine artery is done and the blood supply to the that part is reduced. This is used mostly in case of fibroids, and this is very good treatment option which can work very well. But mind well, it should not be given if the patient is planning pregnancy. Now there are studies which say that UAE can be given even if the patient is trying to conceive, and it helps in the patient may conceive also, but there is a difficulty in conception if there is a uterine artery embolization done. Therefore, uterine artery embolization, it should be as far as possible avoided if the patient has not completed her family. Otherwise, for fibroids, uterine artery embolization is an excellent option. And a very big fibroid, if you do the embolization, the fibroid shrinks in size, the bleeding stops or bleeding becomes less, and the patient is happy, and the surgery can be avoided. So this is about uterine artery embolization. Then one new thing which is now available. It is available in Mumbai. It is available in metros. It is available, I think, in Lilavati Hospital also. It is called as MR guided. MR guided means MRI guided focused ultrasound surgery, MRGFUS. MRI is used for focusing the fibroid, and ultrasound waves are given to the fibroid. So this is the technique. This is the technique where you can see this is the fibroid, and this fibroid is actually destroyed with the help of ultrasound waves, and this is done under the guidance of MRI. So it is called as MR guided focused ultrasound, and this is what is done in nowadays to melt the fibroids or reduce the size of the fibroids, and the bleeding also becomes less. Now we come to the surgical options. Surgical but conservative option. So to be in 1%, you have to do what the 99% won't do. If you do something different, then patients will be happy with you. And two options which are available, which are called as conservative surgical managements, and these are TCRE, that is transcervical resection of endometrium, and thermal balloon ablation. So these are my two last points. I will take another. Archana, is it okay if I get give and take another 10 to
Yes,
10,
sir.
12,
Yes,
12
sir.
minutes?
Yes,
Okay,
yes.
so last 10 to 12 minutes, I am coming to the last part of my uh, talk, that is surgical options. But these surgical options are also not hysterectomies. Remember, friends, it is not hysterectomy, it is a conservative surgical management. So, first is you should remember few things. Submucous fibroid, the fibroid which is inside the cavity of the uterus, can be removed with TCRE. TCRE is a hysteroscopic surgery where you can remove the submucous fibroid with the help of a resection of the endometrium. But otherwise, if there are big fibroids outside the uterus, or if the uterus is very big in size, or if there are ovarian tumors or ovarian cysts, in that situation, you cannot use these two treatment options, TCRE and balloon therapy or thermal ablation. So it can be used only in patients with normal uterus. So if the patient comes to you with abnormal uterine bleeding, there is no fibroid or there is no ovarian cyst, you can definitely give option of TCRE or balloon ablation. In case of fibroid like this is called a submucous fibroid, the fibroid which is inside the cavity of the uterus. You can use TCRE because TCRE will help you in removing the fibroid. Actually, this TCRE came from the concept of TURP. You know what is TURP? Transurethral resection of prostate. प्रोस्टेट इन प्रोस्टेट आजकल हम लोग सब टीयूआरपी करते हैं, है ना? तो टीयूआरपी यूरोलॉजिस्ट ने चालू किया, और उसी यूरोलॉजिस्ट ने जिन्होंने टीयूआरपी किया उन्होंने टीसीआरई का भी ट्रीटमेंट चालू किया, where they use hysteroscope for resecting the endometrium, transcervical resection of endometrium. So endometrium was resected, it was removed, and as the endometrium was removed and it was removed, the patient stopped bleeding. So it is very good for the medical management and the patient will get relief. If the patient is not getting relief with the drugs, then you can do this. If you can do it, even if there is a fibroid, but fibroid has to be very small in size, and you should do this treatment only when the patient has completed the family. You can do this under short anesthesia also, but usually you ask the patient to come nil by mouth, and then you do it under spinal anesthesia or epidural anesthesia, which is the best anesthesia. So best anesthesia is spinal or epidural anesthesia. This is the instrument which is used, it is called as Bertocci hysteroscope, and this is the resectoscope which is used, and there is a loop which is used for removing the inner lining. As I told you, spinal anesthesia is preferred, epidural can also be given. General anesthesia is usually avoided. Why it is avoided, I'll tell you later on. But this is the procedure which is carried out under water. It is called as underwater procedure. So what is the medium which is used? The fluid which is used is either glycine or normal saline. Now, the best part is nowadays glycine is not used, because now the new instruments which are coming, they are bipolar instruments. And in bipolar instruments, saline can be used. And that is because the safety of saline is very high as compared to glycine. This is how the procedure is done. I'll show you the videos of this procedure. This is how the procedure is done. You have to, this is the loop which is used. With the help of a loop, you have to just remove the inner lining. And after removing the inner lining with the help of a loop, you can actually use this ball to do the coagulation. So see how जैसे फावड़ा चलाते हैं ना, उस तरीके से inner lining is removed with the help of a loop, and after removing the inner lining with the loop, you can use this balloon or this ball for actually coagulating the surface with the bleeding vessels, and this is how the procedure is done. Now why we are using um, spinal anesthesia and not general anesthesia? Because the most dreadful complication, देखो सब अच्छे से चल रहा है, देखो अभी सब अच्छे से चल रहा है, we are happy, everything is fine, and what happens that everything is fine, and suddenly what happens? There can be a catastrophe. and this catastrophe is very dangerous. The patient may have fluid overload and pulmonary edema and pulmonary embolism, and this happens because of the fluid overload, and that is the biggest problem associated with this treatment. What is that called as fluid overload and pulmonary embolism? And to avoid this embolism, we use normal saline as a medium. It is good. And second thing which we do to avoid this embolism is we give spinal anesthesia to the patient, so that the patient is talking with you, talking to you. She is conscious, because the first sign of fluid overload is disorientation. The patient starts talking irrelevantly, the patient gets disoriented, and then she goes into the fluid overload and pulmonary edema. So here, if you find that a patient is disoriented, immediately give Lasix to the patient, put the catheter, and stop the procedure. If you do not stop the procedure, patient may go into the pulmonary edema and patient may die immediately on table, and that is the most dreadful complication of this TCRE. As I told you, the patient will get relief. Patient will have amenorrhea, scanty periods, normal periods, or no improvement at all. But most of the patients, they get relief. The only problem with this is the problem of complications. And we are also doing TCRA very commonly, but I personally prefer the next treatment, and that is thermal ablation. So to be successful, you don't need beautiful face and heroic body. What you need is skillful mind and ability to perform. So the last treatment option, which I am very happy with this procedure, is balloon ablation or thermal ablation. So TCRE was the first treatment option which was available, but people started realizing that TCRE can lead to the complications which are dreadful. So everybody was looking for the option which is safe. So safer option then came the balloon therapy. This balloon therapy, we have got this machine with us. We use this therapy in the patients of menorrhagia, in the patient which are very obese, very obese patients where you cannot do surgery, the patient where the uterus is normal but the endometrium is thick, and the patient who are having chronic diseases like heart disease, kidney disorders, and where the surgery is contraindicated. In all these situations, you can do thermal ablation. It is a very good procedure, but there are some contraindications. If the patient wants to conceive, if the family of the patient is not completed, you should not do this. If the patient has got latex allergy, you should not do, because the latex is a substance which is used for this balloon. So latex allergy, you cannot do this. And malignancy patients, of course you cannot do this, and you can do this for only one cycle. So that is what is thermal ablation. We must do DNC before doing thermal ablation, because you have to rule out cancer. Malignancy ruled out, DNC done, then you do thermal ablation, and then it is the next point. As I told you, this is the procedure which can be done under short GA, but preferably in spinal anesthesia, and best is the epidural anesthesia. Why epidural anesthesia is best? Because these patients, they get severe pain after the procedure, and this pain can be reduced by giving epidural anesthesia. Now, how to do this? This is a machine which is used. You can see this machine. This is the machine. This is a thermal balloon ablation machine. And we first do the PV examination. We dilate the uterus, and after dilating the uterus, we insert this balloon. So this is the balloon. You can see this is the tip of the balloon, which is made up of latex. And this balloon is inserted inside the cavity. And this balloon, after going inside, it is dilated, and it goes inside. It swells, and this balloon is now filled with the water, which is at temperature of 89 to 90 degrees. And under this 89 to 90 degrees of thermal ablation, the balloon ablation is done. See how it is done. This is the procedure. First, I have done the curettage. After doing the curettage, this is how the balloon is tested. After testing the balloon, the next step is to see this balloon. This is the balloon which is now taken. After taking this balloon, we are inserting this balloon inside the cavity of the uterus. See how it is inserted into the cavity of the uterus. After inserting this balloon inside the cavity of the uterus, you have to wait for heating time of 3 to 4 minutes and therapy time of 12 minutes. So the total timing which is required is 16 minutes. First 4 minutes, it will heat the balloon, and after heating the balloon, At 90 degrees, it will do the ablation of the endometrium. The charring of endometrium is done for the period of 12 minutes, and so ultimately 16 minutes of treatment is done, and the patient is ultimately getting the relief because of this. So this is how it is done. So you can see here the volume stabilization done, and this is the pressure which is used, and ultimately after 16 minutes this balloon is removed, and you can see there is a charring, and this balloon is responsible for charring the endometrium, and the endometrium is destroyed with the help of the heat or 90 degrees of temperature. Now, sometimes it may lead to thermal injury, but you have to be careful. Otherwise, the patient may have thermal injury. And the most important thing is the patient may have severe pain after the procedure. And therefore, as I told you, you can do epidural anesthesia. Sometimes patient has got nausea and vomiting. So if you give epidural anesthesia, then the patient gets relief. And the another complication which is important, and that's why I tell all my patients whenever I do this balloon therapy, I tell my patient that you will get discharge, vaginal discharge. और जैसे जलने के बाद कैसा सीरस डिस्चार्ज होता है ना, वैसे बर्न पेशेंट्स को जैसे सीरस डिस्चार्ज होता है, वैसे ही एंडोमेट्रियम में से सीरस डिस्चार्ज निकलता है. Because you are burning the endometrium, you are charring the endometrium, there will be a discharge which is a serous blood stain discharge which is coming for 1 month. And therefore, you have to be careful and tell the patient that you may get discharge for 1 month. At Omega, we did a study where we did this balloon therapy in 38 patients, and we found that there was amenorrhea in almost all the patients, in spotting in few patients, and hysterectomy was required in only one patient. So it is giving very good results. As I told you, this is how the patient percentage is there. 26% of the patient got severe pain, and 15% patient had discharge. But this can be treated very effectively if you counsel the patients properly. So 37 cases totally done. Most of the patients were obese patients, patients having medical disorders, patients having some kidney disorders, and in all these patients, we got very good results. And 29 patients, they were happy with amenorrhea. 5 patients had scanty menses. Only 2 patients had normal menses, and in only one patient, it failed and hysterectomy was required. So it was only one patient where hysterectomy was required. Otherwise, almost all patients, they were happy and got the relief. I have done balloon therapy of many of my patients, and many of them they are doctors also. And one of my doctor friend, he jokingly says that Chaitanya, हर महिला का 2 बच्चे के होने के बाद बलून थेरेपी कर लेना चाहिए. That is what he says jokingly, because his wife is so happy with the balloon therapy, because the patient does not get menses. But the beauty of this treatment is that hormonal imbalance is not there. You are not touching the ovaries, you are not doing any surgery, so the patient will have good hormone levels. The patient will not get menopausal symptoms. The patient will get relief from the bleeding, and the patient is happy. So that is the beauty of this treatment. So if you just compare these two treatments, I must say that thermal ablation is better than TCRE. A TCRE does not work very well in young patients. If the patient is less than 43 years, does not work very well. But thermal ablation is also not very good in patients with fibroids, with a big uterus, or if the uterus is retroverted. Because if the uterus is retroverted, it is going backwards. The balloon may not be able to, char the endometrium completely, and therefore the patient may not get relief. Otherwise, thermal ablation is always preferred over the TCRE. So what we do at Omega, at our hospital, we usually do proper counseling of the patient, and we offer all the treatment options available. And we also suggest them कि तुमच्या केसमध्ये हे चांगलं राहील, तुम्हारे केस में ये ज्यादा अच्छा रहेगा, and ये करके देखो. We do suggest them, but we ultimately let them decide, because they should be given that empowerment to decide what treatment they want. Also, we discuss with the gynecologist who has referred this patient, and also discuss with the patient. And we also see for the indications, like specific indications. Suppose the patient is having polyp, then in this patient TCRE is better, because if you are removing the polyp and then you are removing the endometrium also. Suppose the patient is very obese, then maybe thermal ablation is better. And we also discuss about the problem of thermal ablation and problems associated with the TCRE. And the TCRE is having serious complications which are not seen with the thermal ablation. So after discussing this, we give them cafeteria approach and let them decide. So I must tell you, friends, that although the success rate for treatment with heavy menstrual bleeding are not as high as the success rate of hysterectomy, because hysterectomy is like na rahega bas na bajegi basuri, but the patient satisfaction rates are surprisingly comparable इंस्टेंट रिजल्ट तुमको नहीं मिलेंगे, इंस्टेंट रिजल्ट के पीछे रहोगे तो तुम खुश नहीं रहोगे, बट ultimately it gives you very good satisfaction to the patients. So ultimately what is important is you should have a cafeteria approach. You should have clear idea in your mind that what is the treatment option which is available for any given patient. You should discuss everything with the patient and her husband. You should assess the situation and just do it, because whenever you say I will try, you never do it. And Nike says just do it, and you, if you just do it, then you will definitely get the results. So जो सफर की शुरुआत अच्छे से करते हैं, जो सफर की शुरुआत करते हैं, वो मंजिल को पार कर लेते हैं। एक बार चलने का हौसला रखिए, अच्छे इंसानों का तो रास्ते भी इंतजार करते हैं। एंड आई मस्ट गिव यू अ वेरी गुड एंड important take home message that minimally invasive procedures that we have discussed today are here to stay. Patience, people say patience pays, but here, patience pays less in terms of money, but more in terms of satisfaction. And ultimately, at the end of the day, what you require is satisfaction, and patients are happy, so you are also happy. And that is what is the take home message. I am really thankful to you all for giving me this wonderful opportunity. Special thanks to Archana. And it was really very happy moment for me, and I really enjoyed interacting with you all. I think we should have now physical meetings, because now physical meetings are possible, and I think then one-to-one interactions will be much better. But of course, this is a good start. We have started with the Zoom platform, and soon we will meet in person, so that we all can have, heart-to-heart talk about how to go ahead with the management of abnormal uterine bleeding and how to save the uterus, because that is our ultimate aim. Save the uterus is our mission. Save the uterus is our motto. Once again, thank you very much. Thank you.
Thank you so much, sir, for this very informative and wonderful talk. It was indeed very practical session, sir, and most important, sir, it is sweet for all of us to hear you. So thank you so much for accepting this invitation. And really, sir, it was very informative, very practical, and you spoke to your heart, sir. Thank you so much. So it's time for question answer. If with your permission, we'll go for question answer. For this, I would like to request Dr. Jagruti Patil to please take the Q&A session.
Thank you so much, Dr. Archana ma'am, and thank you so much, sir, for this wonderful lecture. So I request all the participants, if you have any question or any queries, put your question in the chat box or directly unmute yourself and ask your question. Sir, the first question is, if a patient is known case of hemophilia and she is in the pubertal age and she will land in the menarche, so how will we manage her menstrual life, or in future is her obstetric life?
Yes, I think this is a really challenging situation, especially when the patient comes to you with the first bleeding as a very heavy bleeding, and this happens many times nowadays. It is becoming very common. So what you have to do in this situation is you have to go to the base. You have to find out the cause, and the root cause should be treated first, because they have some hemophilic disorder, some coagulopathy, or some bleeding disorder which is responsible for the bleeding in menarche, because the uterus becomes the source of bleeding. It is from the uterus that the patient starts bleeding, and the patient may have this puberty menorrhagia which may lead to severe anemia, and it can be life threatening also. So I think in this situation the opinion of hematologist plays a very important role. And nowadays, with the advancement in the treatment of hemophilias and other disorders, hematological disorders, you can definitely give them good option of treatment, because our role is restricted to the uterus. We are here to treat the bleeding associated with the uterine problem. But if the problem or the cause is a central cause, then you should treat the central cause with the help of a hematologist.
Thank you so much, sir. The next question is from Dr. Ashlesha. If uterine cavity is distorted due to fibroid, how can one put Mirena inside?
Yes, this is a very important and interesting question. As I told you, Mirena is sometimes difficult to insert and difficult to put the Mirena inside the uterus. But with experience, I am sure that you will be able to do that. Second thing, you should, and you may have to give anesthesia in some situation. You can give anesthesia, that is not a problem. You should do the proper counseling of the patient. You should tell them to come kneel by mouth and put it under anesthesia. Third point, if you have a fibroid which is distorting the cavity, you can still put the Mirena under USG guidance. So ultrasound comes here as a handy help for you. You can we have in our OT, we have an ultrasound machine in our operation theater where we can use ultrasound for many situations, like if the patient has got incomplete abortion, if the patient has got some problem with the products of conception, or if it's such situation arises that the patient is not, you are not able to negotiate the os and you are not able to put the Mirena inside, you can definitely take the use of help of ultrasound.
Thank you so much, sir. The next question is, can we give equine estrogen injection for DUV?
Yes, nowadays equine estrogen injections, yes, they can be used. It is mentioned in the books, and even the testosterone injection. I remember we used to give testosterone injections for the heavy bleeding, and it is said that equine estrogen can be given as a emergency for the patient with heavy bleeding. But I must tell you, in my 30 years of experience, I have never given equine estrogen injections in my clinical practice, and it was not required at all. If you give this Primalute N, which is norethistron, in a high dose of say 10 milligram TDS, usually within 48 hours the patient's bleeding stops. And of course, tranexamic acid can be given along with that.
So sorry to interrupt you. So kindly make me host because a few of the participants are interested to ask you questions, but they cannot unmute themselves. So I'll do that. Just make me host, sir, please.
Acha, you are not host. Okay, I'll make you host.
I'm co-host.
Okay.
I'm not the authority to.
Now you are host.
Yes, sir. And thank you so much, sir.
Yes.
Dr. Jagriti, please continue.
Yes, thank you so much, sir. The next question is, sir, young girl with just married having huge posterior wall fibroid around 24 weeks. What will you prefer, myomectomy or conservative management?
Myomectomy. It all depends on the size of the fibroid. 24 weeks fibroid, you cannot keep it inside, because one thing, if the patient is planning pregnancy, the first thing you have to do is remove the fibroid and then plan the pregnancy, because otherwise she may abort, or it will not be possible for the pregnancy to grow if the uterus is so big. So there are some guidelines. See, as far as the fibroids are concerned, few guidelines you all should remember. One point, any fibroid which is submucous, should be removed irrespective of the size. Remember one point. So if the fibroid is inside the cavity of the uterus, any fibroid which is submucous should be removed in respect of the size, because this submucous fibroid will definitely have its impact and will not lead to patients to conceive. The patient conception will be a problem. Any fibroid which is intramural, should be removed if it is more than 5 centimeters. Now, some people say 5 centimeters, some people say 4 centimeters, some people say 6 centimeters. But on average, any fibroid which is more than 5 centimeters should be removed if it is intramural and if it is indenting the cavity. Any fibroid which is subserous, guidelines say that any fibroid which is subserous should not be removed for fertility, because the fertility is not related to subserous fibroids. Subserous fibroid will not lead to infertility. So do not remove subserous fibroid. But again, this is for fertility. What about pain? What about pressure symptoms? Suppose there is a subserous fibroid which is 10 centimeter in size. So it will have pressure symptoms. It will press on the bladder. It will press on the bowel. It may lead to hydronephrosis. So you have to remove it for pressure symptoms. What about pain? If the patient has got pain, then you have to remove it. So it is your clinical acumen. It's a clinical judgment which you have to use. But there are guidelines which are there, and I have told you the guidelines.
So, similar question about this question. If the fibroid is submucous and as the fibroid will regress after menopause, then if the patient is approaching the menopause and she is having the submucous fibroid, should we suggest her to do hysterectomy for
Yes.
the menorrhagia, or should we give conservative treatment?
it's a good question because it all depends on how the patient behaves. Suppose there is a submucous fibroid. Imagine a situation, a submucous fibroid, which is, say, very small, 1 centimeter in size, and the patient is 51 years or 52 years of age. In 6 months, she may land up in menopause. And now you have to, you have to buy some time. And after some time, the patient may get menopause and the fibroid will shrink again further. So in that situation, you can definitely try some medical management and just pull on for some time. Like we have discussed about mifepristone. We can use mifepristone in that situation, and this mifepristone may help her to pull on, and the patient may get relief. So definitely, in such situations, there is no need of hysterectomy. If the patient is bleeding heavily, if the fibroid is very big in size, then you have to go for hysterectomy. Otherwise, a small submucous fibroid also you can avoid hysterectomy.
Thank you, sir. The next question is, what is the line of treatment in multiple fibroids with menorrhagia in young age group patients?
Myomectomy.
Okay.
Because
The next
menorrhagia is
is,
there, that means you have to give myomectomy because its patient is young. So young patient with multiple fibroids with menorrhagia, and she wants to conceive of course, because her pregnancy is in place she's planning for pregnancy, then you can do myomectomy in such patients. But if
okay.
the patient is having small fibroids and the patient is not interested in childbearing, then you can definitely think of the medical management.
Thank you, sir. The similar question according to this question is, in focal adenomyomectomy, what precautions we should take if we entering the endometrial cavity, whether we should suture it or leave it?
Again, a very important and interesting question. Uh, Initially, it was said that if you open the cavity, then the patient may have weak scar and the patient may end up in ruptured uterus during pregnancy. But nowadays, it is said that if you open the cavity, it does not matter. And suturing of the cavity leads to proper healing and there will be no problem in future. So if you accidentally open the cavity, don't do not panic. Don't get disturbed. Just suture the cavity properly. The cavity will heal very nicely and you will not have any problem in future.
Hello, sir.
Thank you, sir.
This is Dr. Priyanka, and we are happy to see you on this platform. So we are waiting for this session actually.
Thank you, Dr.
And
Priyanka.
of course, it was a wonderful session that we are having today.
Thank you so much.
My just questions regarding the adenomyosis, like what we should do during the diffuse adenomyosis in such cases who wanted a pregnancy, and later on, what are the pregnancy outcomes in such patients if we are if it is a diffuse adenomyosis and means the uterus is quite big
Big.
in that sense.
This is becoming a serious issue nowadays. Adenomyosis, which is focal, is also difficult to treat because
Mhm.
if you do fibroid, very easy to
Yeah.
remove. Fibroids, they are doctor friendly, they are
Yes.
surgeon friendly. You just
Yeah.
give a nick and a
Yes.
fibroid will
Yes.
pop out and it will come out, and the patient
Yes.
is happy, you are also happy. But adenomyoma, if you try to remove it, you will not be able to remove
Yes.
it. You have to do
Yeah.
adenomyomectomy, but adenomyomectomy may not work at all. As far as the diffuse adenomyoma is concerned, diffuse adenomyoma definitely has an impact and on fertility, and the patient will have definite problem
Hmm.
in infertility. We have many patients of infertility for IVF, especially the adenomyosis is very common after the age of 40 years. So any patient around 40 to 45 years of age, adenomyosis becomes a major problem. And in that situation, you will not get very good results as you are expecting in normal patients. But friends, one thing you have to remember,
Hmm.
that if you focus properly on the endometrial lining, if you focus on endometrium, if you give very good endometrium to this patient, the pregnancy is going to get give her relief from adenomyosis. What happens that if the patient
Okay.
conceives a huge fibroid, suppose a adenomyoma is there and a uterus is 12 weeks pregnant, size uterus. So uterus is bulky, a big uterus, and adenomyosis. But if the patient conceives, then actually the pregnancy is the remedy for her adenomyoma and adenomyosis. The patient will get relief from the adenomyosis, and the patient may not have adenomyosis in future because all the drugs which are given for endometriosis and adenomyosis are actually creating a condition of pseudo pregnancy. These drugs, all the drugs which are available,
Yeah.
like Dynogest or Lupride or any drug, it is
Androgen.
pseudo pregnancy. So it's a pseudo pregnancy. So if you give them real pregnancy, then real pregnancy will give them baby and relief from the adenomyosis also. And the fibroid may adenomyoma may shrink in size. So they
But
may
in
not
that
have any problem.
case, in that case, what may be the means like can we face the preterm labors or the abortions in
No,
such cases?
usually if the patient conceives and the pregnancy is doing well, the problem of abortions are there, but the preterm labor are not much. So if you take, of course, she becomes a high risk pregnancy. You have to take care of her properly. But if you give them proper treatment, then usually such patients they do very well. So you have to tide
Okay.
for the first 12 weeks of pregnancy. Once you tide that period of first trimester, usually patients do well.
Okay. And sir, what should be the criteria while doing the means studying the radiological images in such adenomyotic patients? Whether we should go for the conservative or directly we should go for the surgery?
No.
So
Okay. Tell me.
yeah.
You were saying something?
Yes, yes. Means if we are means trying to get some idea from the radiological images of these adenomyotic patients. So, what are the criteria to define for the conservative management or for the surgical management?
It is very clear. Radiology is one of the part of investigations which you do. You have
Yes.
to consider three important things. One is patient's desire for pregnancy. Two, patient's severity of bleeding, that is menorrhagia. And three, patient's severity of pain, that is dysmenorrhea. Because all the patients of adenomyoma will have dysmenorrhea and menorrhagia. Some patients have more dysmenorrhea, some patients have more menorrhagia, but usually it's a combination of dysmenorrhea and menorrhagia. So there is no such cutoff point where you have to remove the uterus and not to remove the uterus. There is no such cutoff point. You can take the help of ultrasound, you can take the help of MRI. Why? Because MRI and ultrasound will give you not only give you idea about the size of the uterus, but will also give you idea about the pressure symptoms. Like MRI करने के बाद your radiologist will call you, अरे देखो वो सब ठीक है लेकिन वो एडिनोमायोमा जो है ना उसके कारण उसको राइट साइड में हाइड्रोनेफ्रोसिस हो रहा है, मतलब उसको यूरेटर कॉम्प्रेशन हो रहा है, मतलब प्रेशर सिम्टम्स आ रहे हैं, या फिर वो वैसे भी बताते हैं कि ब्लैडर के ऊपर उसका प्रेशर आ रहा है. सो प्रेशर सिम्टम्स, द साइज ऑफ द एडिनोमायोमा, the symptoms associated with the adenomyoma, all these things you have to take into consideration, and it is the approach, it is a clinical approach which depends on various factors. So the radiological factor is one of the factors, of course, but there is no such size. But I must say that if it is more than 12 weeks uterus, usually the patient has got more symptoms, so you may have to think about the hysterectomy.
Okay. Next questions. Jagruti, please carry
Yes,
on.
ma'am. Yes. Sir, the question is about hysterectomy in pelvic organ prolapse. If the patient is of age 30 years and according to ICS and IUGS criteria, she had third degree uterine prolapse, means beyond the 1 centimeter from the hymen, then what will be the best management if she completed her family? Should she go for the surgical or hysterectomy or sling operation?
Whenever you do sling operation, you have to counsel the patient regarding the possibility of recurrence of prolapse after some years. But if the patient is desiring of family, there is no question. But your question is very specific that she has completed her family. Still, I would prefer sling surgery in this patient. Why? Because she is very young. At the age of 30 years, there is no point in doing hysterectomy. Now, I'll tell you one more important point. Whenever we do hysterectomy, it is said that up to the age of 65 years, you should not remove the ovaries unless it is indicated. Like there is no ovarian cancer, there is no ovarian cyst, you should not remove the ovaries. So you have to retain the ovaries even at the age of 55 years if the ovaries are normal, because the ovaries, though there is a menopause, ovaries are still functioning, and this functioning of ovaries will help you this patient to tide over the menopausal crisis, and surgical menopause will not happen. But at the same time, whenever you do hysterectomy, you are applying clamps to the adnexa, and this applying of clamps to the adnexa and removing the uterus will to some extent hamper the blood supply of the ovaries, and the ovaries will definitely will reduce the functioning or efficacy. So the efficacy of the ovarian function is reduced by any surgery, even if you do not touch the ovaries. So as far as possible, I must say that at the age of 30 years, you should not go for hysterectomy. You must, and sling surgery works very well. We do sling surgery laparoscopically, and it works very well. So you must do sling surgery in such patients, and laparoscopic sling surgery is also, the recovery is also very good, and the patients are very happy.
Okay. Thank you so much, sir. The next question is role of letrozole in adenomyosis.
Yes, of course, letrozole is a aromatase inhibitor, and it is a drug which is used for adenomyosis. I have not discussed about letrozole because it is not a first line treatment. Nowadays, diagnosis is the first line treatment. But yes, letrozole can be given. But I personally, I don't use letrozole in adenomyosis. I don't use it.
Sir, shall we give some oral medications also if we insert the Mirena? And shall we follow with this anti-estrogenic drugs like letrozole and all?
You can,
So,
yes, madam. As I told you, you can try a combination also. You can try letrozole, or you can try Dynogest, or you can try GnRH agonist for first 3 months. And after 3 months, you stop this drug, and Mirena will start functioning.
okay.
Thank you so much, sir. The next question is role of cabergoline in adenomyosis.
Again, see, there are many drugs which are available. Cabergoline, I have never used for adenomyosis, and I have no personal experience with cabergoline. We use cabergoline, of course, in the patients of hyperprolactinemia, as you all know. We use cabergoline for the patients of OHSS also, in hyperstimulation syndrome also. We use cabergoline in the patients who are having galactorrhea. But then I have no experience of adding cabergoline in adenomyosis.
Thank you, sir. The next question is if patient is complaining of menorrhagia and she requires 8 pads on day 4. So should we advise her Tranexa on day 4 or not?
Yes. As far as Trenexa is concerned, I will tell you few practical points. I personally feel, and this question is important because you have specifically asked about day 4. I have a personal opinion that tranexamic acid should not be given on day 1 of the menses. Because what happens, let the endometrium shed off. First 3 days, the endometrium should shed off. But in spite of the heavy bleeding for first 3 days, on the 4th day the patient is still having bleeding, then definitely, of course, the first line of treatment is tranexamic acid, because tranexamic acid will immediately stop the bleeding, and it is a short-term therapy. If you give pramulotane to the patient, or if you give regesterone to the patient, or if you give medroxyprogesterone to the patient, you have to give it for 21 days. You cannot give it for 2 days and stop it. If you stop it again, the patient will have withdrawal. But tranexamic acid is one drug which works for a short-term period, and therefore for 3 days, one BD for 3 days, or whatever dose you can suggest to the patient, you can definitely try, and you must try tranexamic acid as a first-line treatment after 4th day of menses. And this is a good question, because first 2 to 3 days you should let the endometrium shed off. Otherwise, what happens? The patient stops bleeding. After 2 days, again she will start bleeding because the endometrium is not shed off.
Thank you, sir. Sir, and in her reports of USG pelvis, the endometrium was 7 to 8 mm.
Millimeter. 7
Yes,
to 8
yes.
mm is okay. It is not very thick endometrium. It is not very thick endometrium. You can give
On day 5,
tenets.
is it okay? On
It
day
is
5,
okay.
is it okay?
It
Okay.
is okay because it is less than 9 millimeter. So usually if it is 12 millimeter to 14 millimeter, the patient will continue bleeding, because this is a classical case of metropathia hemorrhagica, where the patient, first there is a irregular ripening, and then there is irregular shading. The patient continues to bleed over the period of 10, 15, 20 days, and the only option many times is to do the curettage. So the curettage, that is called as therapeutic curettage, is the only answer in very thick endometrium. But 7 millimeter endometrium is okay. I mean, it can be controlled with medicines.
Sir,
Thank you
as
so much, sir.
we were talking about the transcervical resection, so what about the cornual endometrium that we cannot resect on that side much more? So
Yes.
does it will secrete, and what it will impact further? Does it
Yes.
cause pyometra in such during that?
Yeah, I'll tell you. See, there are roller balls also available. You can use them for the corneal side. Then you can do the resection with loops on the anterior and posterior wall and lateral walls. But as I told you in my talk, if the age of the patient is less than 43 years, it is said that TCRA does not work very well. Why it is said like this? Because as you rightly said, there are some patches or areas where you may not be able to reach. And then in that
Yeah.
situation, and if the patient is say around 40 years of age, then regeneration will happen, and the
Yes,
regeneration
definitely.
will occur, and definitely this regeneration will lead to bleeding. So that is the reason why a young patient TCR is not a good option, because you may not be able to completely reset the endometrium. But
Yes.
in thermal ablation, what happens? The balloon fits into the cavity and it charges the endometrium completely. And therefore, usually this problem is not there with the thermal ablation, which is seen very commonly with the TCRA.
Okay. And we cannot even, it is used for the endometrial hyperplasia related with the adenomyosis. Means if the patient is having adenomyosis with the endometrial hyperplasia, we cannot use TCRE or the balloon therapy.
No, my opinion is you should not use, because then
Yes.
the patient satisfaction is not good.
Yeah.
This adenomyoma may lead to problems, and then patient will say कि तुमने तो treatment तुम्हारे अच्छे से किया ही नहीं. So any patient with a hormonal imbalance, with thick endometrium, with normal uterus is the best patient selection for the thermal ablation, and even TCRE. Adenomyosis patient, you should not do this. TCRE भी नहीं करना चाहिए, and even thermal ablation भी नहीं करना चाहिए.
Okay.
Thank you so much, sir.
Dr. Jagrati?
Yes, ma'am.
Yeah, we are running with the time now.
Yes, yes.
I think
Sir, the
actually
only the
ये
last.
सेशन ऐसा लग रहा है कि खत्म ना होना चाहिए अभी. We have a lot of questions, lot of queries, and sir is explaining in a very simple manner that yes, we definitely want to watch you again, sir. We will definitely
so much.
plan to hear you again.
Thank you
And
so much. It was real pleasure. Even I enjoyed the interactive session. It was really, and very good questions. I mean, the to the point questions, and it was really enjoyable.
Thank you,
Thank you
sir.
so
Thank you
much.
so much.
Thank you, sir, for solving our all queries, and it will be running ahead in future. So, on behalf of Nima Obgy Society Central and Nima Obgy Society Maharashtra body, I would like to express my gratitude to all the dignitaries of Nima Central. I extend my gratitude to our Nima OBGY Central President Dr. Kamini Divan ma'am, Secretary Dr. Priyanka Nakade ma'am, Treasurer Dr. Vishnu Bhavane sir, Convener Dr. Rajesh Utne sir for supporting and guiding us to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Chaitanya Shembekar sir, who took time from her from his busy schedule and deliver very knowledgeable and wonderful session. I would further like to extend my gratitude to all dignitaries of Nima OBGY Maharashtra. I would also like to thank Dr. Gesh Daga sir, Dr. Arpita Shah ma'am for the help and technical support. Last but not the least, I would like to thank from the bottom of my heart to all the delegates of for their participation and presence. Presence without them, this webinar would not have been possible and succeeded. I also want to thank Dr. Archana ma'am for coordinating today's webinar. Now, with due permission to all the dignitaries, I am concluding today's webinar. Thank you all for attending and hope you have learned and gained great knowledge from today's speaker. Thank you. Thank you all.
Thank you so much.
Thank you. Thank you so much.
Thank you
Yes.
so much, sir. Thank you.